DSM-III Personality Disorders, Diagnosis and Treatment, by Alan Francis, M.D., Professor of Psychiatry, Cornell University Medical College, and co-editor of the journal Personality Disorders. This is the second cassette in a 4-tape program. It is published by BMA Audio Cassettes, a division of Guilford Publications Incorporated, New York, New York.
The masochistic or self-defeating personality disorder. This is not an official diagnosis within DSM-III, although many people suggest that it should be. It has been recommended as a diagnosis for DSM-III-R. However, this suggestion has stimulated really remarkable controversy. Those of you who live in New York may have seen all kinds of articles in the New York Times. Time magazine has had a feature article on this. The women's groups within both psychiatry and psychology are very concerned that by including a masochistic personality disorder, the blame for relationships which result in women being victimized will be placed on the woman rather than on the social situation or the husband. So that the women's groups are concerned that this is a diagnosis that will be used in a stereotypic fashion, particularly applied to female patients, and will be used as an excuse for blaming them for the trouble they get into, rather than for looking for other causes of their victimization and correcting those other causes. The argument for including a masochistic or self-defeating personality disorder is that such individuals do certainly present in clinical practice, that this has been a widely described condition both within the psychoanalytic and also the interpersonal and psychological literature, and that by not including such a characterization, we are depriving such people from needed treatment. It does no favor to a masochistic individual who repetitively gets into self-defeating situations to ignore the recurrent pattern in his or her life, or to attribute all of the variance to external circumstances. It's also not clear the degree to which there would be a strong female bias in the prevalence of masochistic personality phenomenon, because certainly it's been described in the literature very frequently amongst men, and it doesn't seem to be a stereotypically female condition, even though the early psychoanalytic formulations probably erroneously attributed this to the vagaries of female sexual life. Well, there are no official criteria for a masochistic or self-defeating personality disorder. There's not even a clear title for the condition. However, it's useful to discuss some of the items that have been suggested for a criteria set. The major construct is an individual who has a pervasive pattern of self-defeating behavior, as indicated by the repeated, recurrent occurrence of a number of self-defeating types of activities. These are people who rarely do things that are pleasurable, despite having opportunities to have fun. They often fail to accomplish tasks that would further their progress towards important life goals, despite having all of the abilities to accomplish these tasks in contexts where success is not in the balance. So these are people who manage to grab defeat from the jaws of victory. For example, a patient who's unable to write his own papers, even though he's great at helping everyone around him write their papers for school. These are individuals who tend to be bored with or rejecting of people who treat them well, and to gravitate towards people who treat them poorly. They respond to success often by being made more anxious or depressed rather than feeling happy. They may reject help or assistance from others. They just don't believe the praise or compliments that other people give them, feeling that these are not justified. And they tend to emphasize to others their own particular weaknesses or perceived shortcomings. So they're always leading with their worst side. Now, these behaviors are meant to be characteristic of the long-term functioning of the individual and not restricted to an episode of depression, because anyone looking at these criteria would notice that many of them may be characteristic of acute depressive episodes. The masochistic or self-defeating individual is meant to display these in the long-term, pervasive way that all personality disorders are defined. And the other thing that's probably to be included in any definition is that the behaviors don't occur only in response to a situation in which the patient has no alternative. So that if a patient behaves in a self-defeating way and accepts a painful interpersonal relationship in a situation where indeed they have no choice, that would not be masochistic behavior. Masochistic behavior requires that they do have a choice and that the pattern is recurrent despite that choice. Also, these criteria shouldn't apply to the self-defeating behaviors that happen to people because they're not smart or they're neurotic or they're depressed, or in other words, anyone who has any sort of psychological or emotional problem may get into trouble. The point with a masochistic person is that it's more specific. It's not the non-specific lack of success. It's a lack of success because success itself is something the person has trouble dealing with. Masochistic individuals expect the worst in everything, and they usually manage to find it. They repeatedly subvert their own goals. They turn people against them. They punish themselves, and they elicit punishment from others. Masochistic individuals are especially difficult to treat because they expect the treatment to fail, and they may act in a provocative fashion that makes this quite likely. They are prone to negative therapeutic reactions. That's getting worse when one might expect them to get better. This may arise from their guilt over benefits of treatment, the need to prove that the therapist is sadistic or incompetent, and or a need to maintain autonomy, not allowing that the therapist was able to help them in any way. Negative therapeutic reactions in masochistic individuals are usually mild, but they may occasionally be life or treatment threatening. And this must be considered in any evaluation of the patient's previous treatment experiences. Masochistic personality disorder patients are overly represented amongst the treatment failures in all sorts of medical as well as psychiatric settings. It is important that the therapist recognize the limitations of the situation and not be drawn into feeling guilty or angry about the patient's seeming lack of success either in or out of treatment. The therapist should provide steady availability, endurance, and a strong sense of self-worth. Masochistic patients usually elicit sadistic responses from the therapist, who must be comfortable enough with such behavior to provide it appropriately and in small doses, and then render the interaction available for analysis. Masochistic patients are also always, to a degree, sadistic. The therapist may develop a masochistic countertransference or respond with fury unless he is able to analyze his own and the patient's reactions. This can be true in one session just as much as it can be true after 5 years of work with such a patient. So that one must be aware that if you're getting particularly guilty or particularly angry at a patient, and there's no apparent reason for this, that they may be masochistic in pulling these behaviors. There may be a significant overlap between masochistic personality disorder and various kinds of affective disorder, particularly atypical depression. Some masochistic individuals may indeed respond to antidepressants, and this should be especially tested in those who have accompanying vegetative symptoms or a personal or family history of affective disorder, or on testing have a short REM latency, on sleep testing, or those who've had a failure of response to other treatments. Now, it's possible that masochistic personality disorder patients may respond to cognitive behavioral treatments similar to those that have been devised for depression, particularly by Beck's group. Beck's treatment focuses on the irrational logical assumptions that underlie depression. And really, these are the same kinds of assumptions that underlie masochistic personality disorder, especially catastrophizing, arbitrary inferences, and overgeneralizations that predispose the person to feel badly about themselves and to self-defeating behaviors and beliefs. Now, it's also notable that masochistic patients are often engaged in a complementary relationship with a dominant sadistic partner. The most effective treatment may include this partner in a marital therapy so that the systems issues can be investigated and hopefully changed. The psychodynamic treatment of masochistic behavior focuses on the interpretation of the patient's underlying unconscious fantasies. The patient's self-defeating behavior is traced most often to guilty fantasies that pleasure and success must be linked to and paid for with emotional pain. This may frequently coexist with a fantasy in the masochistic patient that his self-defeating behavior allows him to reestablish what is perceived to be a necessary tie to a sadistic object who represents both a superego projection and a symbolic recreation of important sadistic objects from the patient's past. So in other words, for certain masochistic individuals, when they're suffering, That, in a paradoxical way, brings comfort because it establishes a tie towards a sadistic person that's reminiscent of the tie they had towards early people in their lives that they experienced as being sadistic. Some masochistic individuals fail repeatedly, both in life and in treatment, because they fear that success will result in too much being expected of them in the future. Depending on one's circumstances, the psychodynamic treatment of masochistic personality disorder may be brief and focused, or in some instances it may require the intensity and duration of a full psychoanalysis. Now there's a whole other kind of supportive treatment for masochistic personality disorder patients that uses psychodynamic understanding but doesn't require or use interpretations. For instance, say a masochistic individual is hospitalized, again, say for a heart attack. The approach here would be not to interpret the patient's need for suffering, but rather to compliment them for being very brave in enduring their suffering and difficulties. The therapist listens empathically to the patient's complaints and suffering without attempting to enlighten the patient regarding his or her contribution to and need for that suffering. It's very important to alert the house staff and nursing staff that these are patients who need to complain. Otherwise, the staff is likely to become quite angry at them or impatient with them. Some therapists apply paradoxical injunctions in the treatment of masochistic personality disorder patients. They may argue that the patient, if anything, has underestimated the difficulties involved in his or her life. So the patient comes in and records a litany of terrible activities and terrible problems, and the therapist points out that the patient, if anything, is underestimating how bad it is. This intervention can be dangerous, particularly if the patient is more depressed than masochistic, because it can, in some cases, increase hopelessness. The patient mustn't take the therapist's intervention that things are really worse than the patient has even noticed as a direct and literal assessment of the situation, because that might make the patient become even more demoralized. However, masochistic patients are very frequently remarkably oppositional, so that when the therapist points out that things are even worse than the patient had imagined, these individuals are likely to rise to the bait and to oppose the therapist's pessimism with increased optimism in attempts to find and to promote more positive features in their life. However, it's a high-risk endeavor because depressed and demoralized patients may get worse. It's hard to be optimistic about the treatment of masochistic personality disorder patients because they so often subvert all of the best efforts of the various different kinds of therapies that have been used to treat them. On the other hand, once again, when the treatment works, the results are amazingly gratifying. That people who previously have been unable to enjoy themselves begin to experience a part of life that was previously beyond their reach. The paranoid personality disorder, as it's defined in DSM-III, is probably on a spectrum with normality on one side and paranoid disorders on the other. The paranoid personality disorder is characterized by pervasive suspiciousness, mistrust, hypersensitivity, and restricted affectivity. There have been really very few criticisms of the DSM-III criteria, although Seaver and Kendler have suggested that the criteria are too inferential and fairly nonspecific, and that therefore they result in frequent overlap with other Axis II disorders. The paranoid personality disorder individual is someone who expects without sufficient basis to be exploited or harmed by others. He's likely to unjustifiably question the loyalty or trustworthiness of friends and associates, and to read hidden threats and meanings into really benign remarks and situations. There's always a hidden meaning to the paranoid individual. A conspiracy is always lurking in the shadows. Such individuals are very reluctant to confide in others, for fear that the secrets will get out and be used against them. These are individuals who are easily slighted and quick to counterattack and react with anger. And once crossed, they may bear a grudge for a very long time and never forget a real or imagined insult. It's obvious that interviewing a paranoid personality disorder individual is like treading on eggs. The therapist must be particularly careful about the possible distortions with which the patient may hear the various things that are said. It's also wise to be completely straightforward because the patient is likely to read between the lines if there's any room between those lines. So being very, very explicit in the statements that are made is crucial. Therapist countertransference in this situation is, on the one hand, to be reciprocally angry at the patient. Therapists have feelings too and don't like the idea that they're seen as evil, malign, intrusive, and may in some instances tend to react just as the patient expects. The therapist may be frightened to be forthright and to say things that they expect the paranoid patient won't like, but withholding confirms the patient's fear that they're not being told the truth and that they're being lied to. So these are individuals that, no matter how difficult it is to come right out with a statement, it's usually best to make that statement and not to leave any ambiguity in the interview situation. There have been no controlled studies on the treatment of paranoid personality disorder. Indeed, the very nature of the syndrome may make it difficult to obtain the patient's cooperation in a research study. These are not the easiest people to get informed consent on. Stevens and Parks have suggested that the research on the behavioral treatment of social withdrawal, lack of emotionality, and paranoid delusions in schizophrenics might indeed be applicable to the paranoid personality disorder. But it's difficult to see the relevance of much of the research cited. A lever press method of reinforcement that provides candy, cigarettes, or tokens in order to get the patient to talk and sing is not likely to be helpful in the treatment of paranoid personalities in outpatient settings. These patients often possess the social skills and reality testing for which the above treatments were developed. In fact, paranoid patients are often remarkably successful, and reading the newspapers, one often suspects that leaders in business and politics are well represented in this personality disorder. It may have its adaptive features in a situation where watchfulness and vigilance is rewarded rather than maladaptive. There are real treatments in interpreting the pharmacotherapy literature with regard to paranoid personality disorder. Although medications, especially low doses of neuroleptics, have been recommended, paranoid personalities typically lack the florid psychotic symptoms that are most responsive to medications. And moreover, their personality style makes them very suspicious of the medication, very sensitive to the side effects. And some of what we said before for schizotypal personality disorder certainly applies here as well. These are individuals who are likely to misinterpret every side effect and put the worst possible meaning on it. So very often they will not take medication beyond the first couple of days. Under most circumstances, supportive psychotherapy is the optimal approach for paranoid personality disorders, if any therapy will be attempted at all. The therapist should be honest, clear, specific, open, and respectful, with little use of ambiguous or confronting interpretations. This requires an active therapist. A therapist who lays back is likely to encourage the patient's worst fears. Rather than challenge the patient's denials and projections, the therapist should listen patiently and empathically to complaints and should avoid taking sides. It's difficult not to be provocative with paranoid patients, but important. Once a good relationship is established, it's sometimes possible for the therapist to indicate to the paranoid individual how that he or she fulfills his own suspicious prophecies by stimulating in others a tendency to be overly cautious and therefore seemingly deceptive. People tend to avoid being entirely honest with a paranoid patient, precisely because they fear their misinterpretations. However, the tangled web of deceptions inevitably unravels, confirming the patient's worst expectations. The only treatment for paranoid individuals over the long haul is a stable relationship which disconfirms some of these suspicions, as the therapist comes through as a reliable person over time. Should the paranoid patient be seen in a medical setting, say hospitalized for a heart attack, the crucial thing in a supportive psychotherapy approach is to get everyone to be absolutely open with the patient and to share with them the reason for every test, why the schedules of the nurses are as they are, what the doctor's rounds mean, and so forth. Otherwise, the patient will read all sorts of things into the ambiguity. These are patients who are constantly listening for straggles of conversation and relating them to their own condition. So that it's important that people, when they round, make clear to the patient what they mean by what's said. Paranoid patients are difficult to treat. They don't often appear for psychotherapy, but sometimes in the context of a long and stable relationship with a therapist, they're able to make dramatic changes and to change the way they perceive the world and other people. Our next diagnostic category will be the schizotypal personality disorder. This is actually a new category that was included for the first time by DSM-III. It's meant to describe the borderline schizophrenic or ambulatory schizophrenic patients who've appeared in many descriptions in the literature, both of clinical samples of patients and also of people who are family members of probans who are schizophrenic. The expectation is that the schizotypal personality disorder is a spectrum condition with milder severity but similar characteristics, which in the more florid form are diagnosed as schizophrenia. The schizotypal personality disorder individual is an odd and eccentric person in ideation, appearance, and behavior. He's an individual who's likely to have no close friends, who's likely to present with inappropriate or constricted affect, difficulty looking the interviewer in the eye. His speech is odd but doesn't have the same degree of loosening of associations and incoherence as is characteristic of schizophrenics. His behavior may be strange, with poor personal hygiene, stereotyped mannerisms, perhaps even talking to himself. Patient is likely to be suspicious of the examiner and of other people in his life, but without having the clear-cut delusions that are characteristic of paranoid disorders and of schizophrenia. Patient may have ideas of reference, but not delusions of reference. In other words, he may feel that other people are talking about him, but when pressed, it's clear that the patient doesn't believe this in the face of contrary evidence. These are patients who are very nervous in social situations, and they may have unusual perceptual experiences. It's not uncommon for such patients to describe illusions, the feeling of depersonalization or of derealization. Patients who meet criteria for schizotypal personality disorder often have great difficulty presenting for treatment and are likely to present for treatment only when they have an Axis 1 problem that requires immediate attention. These individuals are just as suspicious and frightened by the prospect of a psychiatric consultation as they are frightened and suspicious in other relationships in their lives. They very often will drop out of treatment early, and so a concerted effort must be made to explain the purposes of various interventions and to enlist the patient's cooperation in them. There has been little controlled study of the treatment of schizotypal personality disorder. There has been some pharmacological research on borderline schizophrenics, but it's unclear whether the results of this research would carry for DSM-III defined schizotypal personality disorder patients. Moreover, the results are unclear. Seaver and Kendler have suggested that the schizotypal personality disorder symptoms of emotional detachment, social isolation, eccentric appearance, social dysfunction, and somatic problems are more effective in identifying borderline schizophrenic than are the cognitive symptoms of strange thoughts and delusions. However, in clinical samples, it's the cognitive symptoms that best distinguish the schizotypal from the schizoid, and certainly that's how the DSM-III handles the distinction. The schizoid and the schizotypal are virtually identical, except that the schizotypal personality disorder has the additional cognitive symptoms. Moreover, Seaver and Kendler were basing their conclusions on the studies of family members of schizophrenics. These individuals generally don't report for treatment. Clinical samples of schizotypal personality disorder patients are characterized as much by the cognitive symptoms as they are by social withdrawal. In fact, it seems clear that clinical samples in this regard are likely to be quite different than the samples gathered from families of schizophrenic individuals, and that the DSM-III definition should be based on clinical samples rather than family samples. There is little controlled study to guide the treatment of schizotypal personality disorder individuals. The pharmacologic research on borderline schizophrenics is difficult to interpret because very often the patient so described would also meet criteria for borderline personality disorder. A number of studies suggest that the use of low doses of neuroleptics may be helpful in schizotypal personality disorder individuals. However, these patients also appear to be especially sensitive to side effects and especially difficult to keep in treatment. A clinical rule of thumb with a schizotypal personality disorder individual is that they should be warned quite explicitly about the possible side effects of the medication. And it should be explained that these are expectable, that they will improve with time, because very often the patient will misinterpret the side effect as being a strange new distortion in body image and may develop all sorts of ideas about what's causing these strange new experiences. So that linking the side effect to the medication clearly in the patient's mind, explaining that these are predictable and expectable problems and that they will go away with time is usually necessary in order to enlist the patient's cooperation in the psychotropic drug management. The psychotherapy management of schizotypal personality disorder patients is difficult. They often have the same suspicions about the therapist as they have in other relationships. They're very prone to drop out of treatment. They're very prone to misinterpret the therapist's behavior, particularly to feel that the therapist is either trying to intrude upon their privacy, on the one hand, or on the other hand is unconcerned with them and would prefer that they not come back for the next session. It's very important to be explicit with a schizotypal personality disorder patient and constantly to test for possible distortions in their understanding of the reality of the treatment relationship. A supportive, relationship-oriented therapy is often the best bet over the long haul if one can establish it. A common therapist misconception is to underestimate the degree to which such individuals become attached to the therapist and to the therapy. Perhaps the most powerful treatment relationship I've ever had with a patient happened with someone who would have met the DSM-III criteria for schizotypal personality disorder. And although it was a very powerful relationship, especially for the patient and also some ways for me, I didn't realize how important it was to either of us at the time. He was a person who had a great deal of trouble talking to anyone, felt very frightened in all sorts of social situations, and constantly felt that other people were teasing him or making fun of him. As a result, he talked to virtually no one during the course of his week. He managed to work, but he had a job which required him not to speak to anyone. His only important relationship outside of the therapy was with his pet dog. And at Christmas time, he would give his dog very elaborate presents, various kinds of bones, dog treats, dog toys. And his dog would give him a bottle of Johnny Walker Red Label. The presents would be opened on Christmas Eve, and this was really his most important relationship. For therapy, he would come in only once every 2 weeks. He didn't want more frequent visits. And our chats would be brief, long periods of silence. There was no reason to expect that anything terribly important was happening during these sessions, but it was clear he was attached to them and came regularly on time. When I had to leave the city in which this treatment was conducted, this was the one patient who found it most difficult to lose the therapy contact. And for many years after I left that city, we would have contacts on the telephone every 2 weeks, again with lots of silence, with very little affect on either part, but the relationship was really clearly very important to the individual. So that because the treatments don't seem filled with excitement, the therapist shouldn't underestimate their importance to the patient.
This ends the side.
The next category that we'll discuss is the schizoid personality disorder. This category overlaps with both the schizotypal and with the avoidant in interesting ways. The schizoid personality disorder is essentially identical in its description to the schizotypal personality disorder if you leave out the odd features in thought and behavior that are characteristic of the schizotypal, so that both individuals suffer from a great deal of social withdrawal, but the schizotypal has added eccentricities in thinking and behavior that are absent in the schizoid personality disorder. Moreover, there's a great deal of overlap between the schizoid personality disorder and the avoidant personality disorder. Again, both disorders are characterized by the avoidance of interpersonal relationships. The major distinction between the avoidant and the schizoid has to do with the motivation for this avoidance. So that the avoidant personality disorder is someone who really would love to have relationships, cries out for them, becomes very dependent once a relationship is possible, but has great difficulty in initiating a relationship for fear of being rejected. The schizoid individual, on the other hand, is someone who doesn't, at least consciously, crave relationships, who prefers to be left alone, for whom rejection is less of an issue and just being left alone and in privacy is the major issue. Now, it must be recognized that this is really a continuum. And as one gets to know a schizoid individual better, very often the craving for a relationship, at least an unconscious craving for a relationship, becomes clearer. But the way the distinction is made in DSM-III would be based on the initial consultation. And here it's fairly clear that some patients will be able to state quite openly that they wish they had relationships but are too afraid to do it. Other patients would say that they are very pleased to be left alone, that they're loners, and that's the way they want life to be, and their major problems happen when people tend to bother them and try to intrude on their lives. The distinction is useful because it has different treatment implications, which we'll be discussing in just a moment. The criteria for schizoid personality disorder would include no close friends or confidants, very constricted affect. These people are usually experienced as being very cold, aloof. They don't smile much. They don't laugh much. One feels like you're in the room with a tin man. The patient usually appears to be indifferent to praise or criticism from other people. They have little desire to have sexual experiences. They very often, especially male schizoids, very often don't marry. Women may more frequently get married. There's little desire for or enjoyment of close relationships. These people almost always choose solitary activities, both vocationally and avocationally. Night watchman jobs, working in the post office, jobs where interpersonal contact is held to a minimum. They generally claim rarely to experience any strong feeling, including anger, that they don't experience love, and sometimes feel as if they're strangers in a strange land, outside the realm of the usual experiences that other people have, which often they are aware of not understanding. These people will say outright that they're not really interested in other people, that mainly they just want to be left alone. As a result, it's uncommon for schizoid individuals to present in clinical settings. So that although the DSM-III definition probably describes certainly a proportion of individuals in the community, they're very uncommonly met with in clinical settings because they're just as shy, just as desirous of privacy in regard to treatments as they are in the rest of their lives. Schizoid individuals present for treatment only when they have another kind of problem. They almost never present or really never present because of a desire to change their schizoid personality. It is important for the consultant interviewing an individual who meets criteria for schizoid personality disorder to appreciate and respect the patient's need for privacy. These are not people who tolerate rapid-fire questioning well. The interview must be conducted at a gentle pace with the expectation that important pieces of information may not be obtainable during the first interview. It's important not to crowd the patient. Similarly, if this sort of patient presents on a medical service and the psychiatrist is called in consultation, one of the recommendations that may be very useful for the house staff is to leave the individual alone as much as this is possible. If a schizoid patient is hospitalized, whether in a medical or psychiatric setting, if a private room is at all manageable, they should have the private room. It will make it much less stressful for them to tolerate the acute difficulties of a hospitalization if they don't feel constantly thrown into contact with the bewildering variety of other individuals in the setting. There are no control studies on the treatment of the schizoid personality disorder. However, there is a considerable clinical literature, particularly contributed by the object relations psychoanalysts of the British school, such as Fairbairn and Guntrip. These therapists indicate that there are considerable barriers in developing a productive therapeutic alliance with schizoid individuals. On the rare occasions in which the patient does engage in an ongoing therapy, it is again quite common for the therapist to underestimate the patient's loneliness and degree of detachment, just as we mentioned before in the example for the schizotypal personality disorder patient. The detached analytic stance is really counter-therapeutic because it reinforces the patient's aloof distance, unless it's felt that at that particular time in the treatment the patient could not tolerate any greater degree of interpersonal closeness. So that the major variable in treating the schizoid individual is to titrate the patient's fear of interpersonal closeness with his desire and need for it. It is important for the therapist to be genuinely warm, respecting, and caring without intruding on the patient's very strong need for privacy. One combats the schizoid social isolation by providing and creating a meaningful relationship. The schizoid's tendency to disavow, nullify, or destroy the human and meaningful aspects of the relationship can be very stressful to the therapist and can create an eerie and unsettling atmosphere of empty shallowness. But as we mentioned before, often from the patient's point of view, the relationship is terribly important, and it's equally important that the therapist be patient. Let's move on now to the histrionic personality disorder. DSM-III defines the patient who meets criteria for this disorder as someone who is self-dramatizing, attention-seeking, who has exaggerated affect, who tends to overreact to minor situations, who craves excitement and is prone to angry outbursts and to tantrums. And this individual is also conceived of as being shallow, self-indulgent, vain, demanding, dependent, and prone to manipulative, suicidal behavior. This category has been subject to considerable controversy. The most important objection has been that it's much more descriptive of traits that are likely to appear in women than traits that are likely to appear in men. And since the people who defined the category were mostly men, the concern is that there may be a stereotyping of female behavior as being personality disordered. This controversy is not really new to DSM-III, and in fact, the DSM-II term, which was hysterical personality disorder, was replaced by histrionic personality disorder precisely because the former had such apparent sexist connotations. Aspects of male histrionic behavior, for instance, exaggerated macho styles of expression of male characteristics and or homosexual mimicry of female traits, are not included within the DSM-III criteria for histrionic personality disorder, and perhaps they should have been. It has been suggested that the bias in selection of the diagnostic criteria for histrionic personality disorder accounts for the fact that more women than men are considered to be histrionic. That if we had criteria that covered macho expressions as well as ultra-feminine expressions, the disorder might be as frequent in men as it is in women. Women who are simply conforming to their sex role stereotype are more likely to be considered disordered in a system developed largely by males, or so goes the argument. The response to this criticism is that there are other personality disorders that are more commonly seen in men, particularly the antisocial and compulsive tend to load in males, and that a covariation with gender does not necessarily imply a sex bias. If one considers personality disorders to be exaggerations of common personality traits, and that is, inflexible and maladaptive exaggerations, then it may not be surprising that females are susceptible to exaggerations of stereotypic feminine traits, and males are more susceptible to exaggeration of stereotypic male traits. But it does seem that DSM-III has focused its attention primarily on feminine exaggerations, and has ignored what are perhaps equally interesting and common male exaggerations. It may be wise for clinicians to do a translation in their own mind and to consider the macho male as having many of the same characteristics as the ultra-feminine female with some of the same treatment implications, even though this is not part of the DSM-III diagnostic system. There's been another type of criticism of the DSM-III criteria set for histrionic personality disorder, and that is that it really selects for a quite impaired group of patients who overlap excessively with the borderline and with the narcissistic personality disorders. That the typical hysterical patient in the especially psychoanalytic literature was someone who functioned at a much higher level of integration and was really much more susceptible to psychologically oriented treatments. Histrionic personality disorder patients tend to evoke two major opposite kinds of countertransference problems in their therapists. Some therapists have a tendency to be seduced by such patients and to get overly involved, and other therapists have a tendency to be indifferent in response to the patient's flirtations and efforts to achieve engagement. It's important for the therapist to be seduced enough to like the patient and to respond to the patient in a warm and friendly manner. Otherwise, the patient may find the therapy absolutely intolerable and may find the therapist a cold fish, someone who's rejecting, and may find him and the treatment boring. Frequently, problems are caused by therapists who, because they feel threatened, react to such patients with a kind of aloof detachment. Attempts by the patient to either sexually seduce the therapist or to establish a friendship outside of the session are common. It is usually wise for the therapist to thank the patient, to explain in reality terms why such a relationship is just not possible, and whenever possible to explore the meaning of the wish and the patient's reaction to its frustration. The choice of the sex of the therapist may be particularly pertinent with such patients, and a therapist of the same sex may often be less interesting but more effective in the treatment of histrionic personality disorder. There are no controlled studies on the treatment of either the DSM-II hysteric personality disorder or the DSM-III histrionic personality disorder. Klein's group has shown the effectiveness of monoamine oxidase inhibitors in the treatment of something they call histeroid dysphoria. These investigators suggest that the personality disorder in such patients is really secondary to chronic affective disorder. Medication rather than, or perhaps in addition to, psychotherapy is necessary to reduce the underlying affective contribution to the pathogenesis of the personality characteristics. Leibowitz suggests that most histeroid dysphorics suffer from some mix of both character and affective pathology, and that they're best treated with some combination of monoamine oxidase inhibitors and psychotherapy. However, this is an opinion not yet confirmed by extensive study. Although there are no systematic studies on the behavioral treatment of histrionic personality disorder, certain possibilities do emerge. Since the histrionic is incessantly attention-seeking and demanding, they might be especially responsive to a reinforcement system in which attention is contingent on more adaptive behavior. Psychoanalytic psychotherapy has a long tradition in the treatment of hysterical syndromes, including histrionic personality disorder, and is still considered by many to be the treatment of choice. This form of treatment is indicated for the higher functioning histrionic personality disorders and may not be suitable for those, for at least some of those, who are described within the DSM-III rubric, especially those that have a pronounced overlap with the borderline personality disorder. The higher functioning histrionic patients tend to do well in all forms of psychodynamic treatment. Often they become more genuine with themselves and with others, and are able to tolerate greater interpersonal and sexual intimacy. In the early literature, the major focus of treatment was on the interpretation of repressed Oedipal wishes and of the guilt and repressive defensive style that was occasioned by them. More recently, the psychoanalytic literature has focused interest on the oral traits and conflicts in histrionic patients, and attention to the fact that the seductiveness is often used in the service of satisfying dependency needs. The lower functioning histrionic patients may require a much more directive and supportive approach. They often settle down in the context of an interpersonal relationship in which they feel accepted, and they may become amenable to advice and to social skills retraining within this context. Although it may often be very difficult to induct a histrionic personality disorder patient into a group therapy, they will often benefit especially from it. At first, such patients are likely to demand the group's attention excessively, to want to be the center of the group, the queen or the king of the group. But with supportive feedback done in a gentle but persistent way, such individuals may, for the first time in their lives, learn how to share. The narcissistic personality disorder is also quite a controversial category. It's a new category introduced by DSM-III, largely in recognition of the extensive psychoanalytic literature on narcissistic characteristics, but also there has been a literature in psychology, and also the interpersonal circumplex have isolated narcissism as an important characteristic for personality classification. The DSM-III concept of narcissism focuses on grandiosity, self-importance, exhibitionism, entitlement, exploitiveness, lack of empathy, and unstable interpersonal relationships. These are arrogant people who are very much taken up by themselves, mostly interested in their own achievements, and excessively self-absorbed with their own lives. A nice example that recently came to my attention has to do with a famous sports figure who I will disguise by calling Bill instead of his real name. He was leaving his wife to marry a beautiful model, and his wife's remark at the divorce proceeding was, "I just hope that she loves Bill as much as Bill loves himself." Such individuals are tough to be married to, tough to work for, tough to work with, and also tough to treat. Patients with narcissistic personality disorder very rarely present for narcissistic personality disorder that they've identified. So that quite commonly, the reason for presentation will be an Axis 1 condition that accompanies the disorder, most particularly depression, either major depression or adjustment disorder with depressed mood. So that quite often something's gone wrong in the patient's life that makes them feel bad, and the reason they come for treatment is that overlapping Axis 1 diagnosis. The other overlaps on Axis 2 that are most common are with borderline personality disorder, histrionic personality disorder, and avoidant personality disorder. And in the frequent situation where the patient meets more than one of these at any given time, it's useful to note all of them. Another reason, by the way, for patients with this disorder to present is very often the insistence of a spouse. So that whereas the patient himself, usually himself, feels that there's no problem, often his wife is driven to distraction, and the final straw that brings the patient to treatment is a threat from the wife that unless he does something about his behavior towards her, she's going to leave. Another frequent cause for coming to treatment will have to do with employers or employees saying similar things, and people feeling that unless they do something fast, they'll be in trouble. Quite often, once the dust settles, such individuals will quit treatment, so that it's wise at the beginning to get as much done as one can, with the understanding that it's very frequent that such an individual will not stay on for the long haul. These are patients who have great difficulty entering treatment. It's a narcissistic humiliation for any such individual, for most such individuals, to need someone else's help and to admit that someone else has something valuable to offer. So such patients are very reluctant to begin treatment, will often drop out of treatment quite early, are easily disappointed, easily wounded, and must be treated literally with kid gloves during the induction phase of treatment, or else it won't last much longer than that. The narcissistic personality disorder diagnosis, as it's defined in DSM-III, has received a number of different kinds of criticism. A number of people feel that narcissism is a characteristic that's ubiquitously distributed and present in varying degrees in most patients, so that it doesn't really deserve a separate category. Others have complained that the DSM-III definition focuses only on the arrogant, grandiose narcissist, and that it really pays too little attention to a more subtle form of presentation that many patients initially present with. These are patients who present with hypersensitivity, feelings of inferiority, intense envy, lack of genuine commitments, inability to remain in love, and often perverse fantasies. They often have other people in their lives to whom they delegate omnipotence, so that they present as very dependent people who are attached to very powerful people. This is a more subtle form of presentation that's been described extensively in the psychoanalytic literature. Kohut took the extreme position that the narcissistic personality disorder diagnosis could not really be made on the basis of the patient's past history and current presentation during a diagnostic interview. He believed that the only way one could make the diagnosis would be to actually treat the patient in psychoanalysis and see whether the individual developed a characteristic narcissistic transference during the early phases of the treatment. Of course, this is a kind of expectation that can't be met in actual practice. I mean, one has to have a method of diagnosis that doesn't require an extensive treatment. There's also been a great deal of controversy, particularly within the psychodynamic literature, about how best to treat narcissistic personality disorder patients. The two contrasting views that have received the most attention are those of Kohut and Kernberg. In Kohut's view, the narcissistic personality disorder individual is someone who has an arrested development at a grandiose phase, which is otherwise a normal phase of development. If such an individual is allowed to enter into a close and nurturing and empathic relationship with a therapist, this relationship will be able to identify the sources of disappointment that led to the original developmental arrest, and the empathy exhibited in this relationship will help to correct for defects in empathy that the individual experienced in his original development. So in the Kohutian model, the patient is seen as arrested in a normal stage. The therapist's job is to be empathic to the patient's vulnerabilities, aware of the disappointments the patient will inevitably feel within the treatment relationship, and able to bring the patient's grandiose fantasies to the fore without undercutting these fantasies or humiliating the patient unduly about them. Others have criticized this as being a form of supportive therapy and suggest that narcissism, rather than being a normal developmental arrest, is instead a pathological manifestation that requires not just empathy but also interpretation and confrontation, pointing out to the patient the degree to which they develop envious and grandiose relationships with others, and attempting to find out what are the underlying conflicts involved in this. So this tends to be a much more confronting approach to treatment. Both recommendations can be performed within the setting of a psychoanalysis, or they can be inform long-term psychodynamic psychotherapy. These tend to be long treatments. Any effort towards character change with narcissistic personality disorder patients is going to take a long, long time. These are individuals who are difficult to induct into treatment. They don't get comfortable easily, and even when they are comfortable, there's a repetitive pattern of disappointment that must be worked through over and over again before the patient is able to overcome the vulnerability to humiliation that forms such an important part of this syndrome. Now, many narcissistic individuals come to treatment at a time in which they've suffered a bruising. Something has gone wrong in their lives. They've experienced what's usually called a narcissistic injury. And a brief form of therapy for such individuals, in effect, helps them to lick their wounds and go back and face the world. The goal here is not to change their character so much as to help them get over this particular stress and maybe become slightly more aware of vulnerabilities that they carry with them so that they'll be protected from future similar experiences. The more supportive therapy for the narcissistic personality disorder individual that we're describing now requires actually admiring them. Such individuals often come to therapy because they have had a short-term deficit in admiration. And if the therapist is able to find things that are generally worthy of admiration in the patient, this is often quite helpful. The way to do this practically is to find topics that the patient likes talking about which he or she has expertise, and to focus on their areas of strength, not just on their areas of weakness. These patients are often surprised that you do this, because they come to the therapy expecting the therapist to knock them down yet one step lower. Thus far, really the only treatments for narcissistic personality disorder have been based on a psychodynamic understanding of the problem. However, it seems conceivable, at least, although maybe a little risky, that cognitive and behavioral treatments may be developed for these problems. A behavioral technique, which has been used by some therapists, is to expose the patient to the anxiety that's consequent on their feeling less than great. So in other words, with such a patient, the therapist might tell them in so many words, in a systematic way, the patient has to agree that this is a worthwhile endeavor, otherwise the therapist is likely to get slugged, but in a systematic way to point out to the patient how they are less than great, how their expectations are grandiose. The patient is meant to experience anxiety through this process and gradually to extinguish to that anxiety so that it becomes less of a powerful hold and they'll be less terrified of being anything but perfect in each new situation. A cognitive approach is somewhat less risky, and that is to point out to the patient how no concrete accomplishment in life would ever be satisfying. That winning the Nobel Prize, an Olympic gold medal, and being elected to president all in one day might not be enough to satisfy the inordinate need they have for perfect success. And so gradually working with the cognitions that the patient presents with that require them really to do more than is humanly possible and that never let them rest or feel proud of anything that realistically is accomplished is often useful. Paradoxical approaches are sometimes helpful. I mean, these are patients who at times require the therapist to be creative because they're often not easy to treat. One paradoxical approach that has sometimes been useful for me is actually endorsing the patient's grandiosity and prescribing it beyond the realm of what even the patient would deem reasonable. So that in some instances it's possible to stimulate the patient's modesty by praising them so much that even the narcissistic patient is forced to blush, and this may bring about a realistic self-appraisal. Typical countertransference reactions are in some cases to work very hard to gain the patient's admiration. These are patients who can make their analysts or therapists feel like 2 cents. And some therapists, under that kind of pressure, will begin to feel like 2 cents and will work very hard to please the patient, to show the patient that he or she is a capable individual deserving of some respect. Other therapists become quite angry and begin to retaliate, showing the patient how he or she, the patient that is themselves not worth more than 2 cents. And battles can occur in which the therapist and patient are working very hard to wound one another in their narcissism. Some narcissistic patients will have the attitude that only a very great therapist could treat me and will greatly idealize their therapist. And some therapists will find this comfortable enough. Some therapists will be blown up with it and will feel so excited by the patient's praise that they take it seriously rather than seeing it as part of the treatment relationship. Other therapists will be embarrassed about it and will have a need to sort of correct the patient's distortion, perhaps prematurely. Some patients may need to idealize the therapist. If the therapist too quickly makes clear that he's not so special, the patient may have to leave treatment. In summary, then, the major thing to keep in mind in treating narcissistic personality disorder patients is that they present really enormous problems in developing a workable therapeutic alliance. These are individuals who are often competitive with a therapist, devaluing, very protective of their autonomy, intent on proving that the therapist has nothing to offer. They're likely to always come up with the interpretation first, or when you say something to reply back, well, I thought about that already. They may treat the therapist with indifference at times, at other times with excessive admiration, and often they fluctuate wildly between these extremes. The therapist may feel angry or inferior in response to these denigrations, or embarrassed by the praise that the patient will sometimes heap with abandon. I think that more than most of the patients we're discussing today, the individual with narcissistic personality disorder requires a therapist whose self-esteem is stable enough to withstand such pressures in both directions.
This ends Tape 2.